Greetings, I'm Professor Kim Jong-un of Yonsei University. I'm honored to see you. I'm honored to participate in this offline event. I'm honored to be given the opportunity to speak here. I would like to extend my gratitude to the chair, Professor Jae-jun Ryu, as well. Today, I'm going to talk about the fabrication protocol as well as ways to minimize deviation. I'm going to talk about my personal experience as well as study results. For successful implant prosthesis fabrication, there are many things to consider. You need to consider vital structure as well as surgical technique and the deep understanding of prosthodontics. First, I'm going to talk about three-dimensional implant positioning. Before I move on to surgical guide, we need to have the basic understanding of what implant needs to be placed, and based on our knowledge, you need to realize that using the three-dimensional guides. The optimal position. If it is placed in ideal position, you can make ideal prosthodontic profile, and oral hygiene can be maintained and maximize the aesthetics of prosthesis. The transmission of occlusal force can be transferred along the long axis and minimize mechanical complications. A lot of people prefer a CRP type, and the screw access hole of the implant prosthesis can be made in the appropriate position. As of late, these surgical guides are used very frequently compared to the past, and I'm sure you have a lot of experience in designing and fabricating surgical guides. A lot of energy is spent. You need to do a lot of planning. You need to prepare ahead. As you can see, there are ways to minimize mistakes and realize our plans into the oral cavity. There are many technologies that help us do that. Because we increasingly use this, we have a basic idea of how to do it. I think we need to focus on the details. That's why I came to come up with this lecture. I'm going to talk about my lecture in three different categories. First is how to get the data acquisition from the patient. The second is to get design and manufacture. Third is to place implant with reduced deviation using the guides. First is data acquisition. As you know, in designing guides, CT data is necessary and tooth surface data is necessary. In CT data, in order to check out the bone, you take a CT in order to really look at the bone. In teeth, there's a lot of artifact. Even if there's no prosthesis, artifact can occur. And surface data needs to be acquired and merging needs to be done to design the guide. First issue is that whether you're going to take impression or intraoral scanning is going to be done. According to a recent review article, it looks into various studies. Taking silicone impression or using intraoral scan. Routinely, we use alginate in this study. The results from alginate were not really optimum. As shown, to get more precise impression, efforts need to be made. Dr. Hee-cheol Kim is going to talk about this, but as you all know, stitching process is necessary. Multiple data needs to be stitched to get three-dimensional data, and how precise the different images are, and how well it is stitched determines the quality. If there are multiple landmarks as shown here, you can get more precise data. However, on the right side, there is quite a lot of edentulous area, and the gingival form and texture, it looks very difficult to differentiate depending on the specification of scanner. It may vary, but in the case of long span edentulous area, there can be many deviation and error in the stitching process, and in recent studies, such error exists. In the case of bite registration, if the edentulous span is long, if there's dentition up to premolar, it's better, but if there's no teeth after canine, bite stability goes down. Another issue is that how long do you do it and the scope. In most cases, rather than long span, oral scanners are recommended to use for single teeth or small spans, a single crown, 2 unit, short span crowns. When we make short span prosthesis, intraoral scanners can be used for optimum results. Second issue is the issue of superimposition. I've talked about how merging is important. And when you merge, if there's a lot of teeth, as you can see, it is shown in green. So it shows that it is precise. If there's not a lot of teeth, and if it is only remaining teeth and narrow distribution, in this case, so there can be many errors in merging. Therefore, artificial markers need to be provided. As you can see, the deviation and error goes down significantly, and this is reported by many studies. This is quite an extreme case. All implants and prosthesis. Every tooth has prosthesis. On the left, it is very difficult to get appropriate information. Even if you have teeth arrangement information, it is very difficult to do merging, and the error in merging leads to error in placement. You need to provide artificial markers to take CT and take impression and scan. You go through these series of processes to acquire data. You cannot make a guide in this stage. You get data with no marker and merge it. This is a study done by myself. A tray type marker can be done, and the tray is formed, aluminum marker is attached. Impression material is applied and applied to dentition. CT is taken. The tray itself serves as a marker in itself. Indirectly, merging is done. The accuracy of surgical guide can be increased. I also use this for final prosthesis fabrication. You can do it more easily because it's quite convenient. In the case of fully edentulous patient, it's kind of different story because the process of merging using tooth is not relevant here. Old denture the patient used or temporary denture needs to be fabricated to do merging and use it for merging. The denture the patient uses is replicated and stent is made, CT is taken, and then the patient using this denture appliance is taken as well for merging. And designing of surgical guide can be done in this way. The most important thing is that whether the denture is appropriate. There are patients who routinely use old denture, but at times if the inner surface is inappropriate, you need to do additional work and get the gingival form. If the internal fit is inappropriate, relining process is necessary. If it is accurate, you can just use it. You need to see the wear on artificial teeth, and there are many things to check. If the old denture is inappropriate, you need to make a temporary denture and start from scratch. This is the second subject, design of surgical guide and manufacturing error. The most important thing is digital wax up. As we make a surgical guide, the final prosthesis design and form is very important. On the anterior area, aesthetics is important, and in posterior area, occlusal path needs to be assessed accurately. You need to understand it thoroughly before we proceed on the posterior area. You not only arrange and align teeth, but at times you reduce the occlusal table. You need to consider these designs ahead before we move on to surgical guide fabrication. To do this, accurate impression taking or scanning is very important. In the posterior area, the surface and the occlusal surface and the form of the tooth is different. In the full contour, there are grooves here. As mentioned, the occlusal surface, if you want to make it smaller, you need to reflect that in the digital wax up. If these factors, contours are not really reflected, the screw access hole can be inclined towards outside and negative results can come to be. Digital smile design is used for aesthetic result. You need to get patient images to do digital smile design and align teeth on the anterior area for the same purpose. Facial scan data can be used as well. You not only look at the frontal image, but the lateral image as well, and profile images as well to look at the teeth. If there are a lot of teeth, you also evaluate the occlusal plane using the landmarks of the patient's face and get good results. Planning software, there are many available. There are different functions available. Depending on the software that you use, you need to understand which functions are supported. On the right is Implant Studio. What I really like about this is that in diagnostic stage, you can use a virtual articulator here. So you can get dynamic occlusion information and do digital wax up ahead. It's a huge benefit. So you can provide customized treatment. Second issue is a sleeve design. In the past, metal sleeve design was basically simple. The tolerance is quite coherent and using mass-produced sleeve. So you have a coherent sense of how you should drill. After you process it, you need to attach the sleeve, so it's quite cumbersome to complete that within the dental clinic, and it can be more costly. As of late, the polymer printed guides are now available without sleeves. The biggest issue here is that on the inner surface of the sleeve, you need to do trimming, and you need to check whether the drill goes in passively, and this is essential for accurate surgery. If you look at the recent studies here, metal sleeve or lack of, there's no meaningful difference. Sometimes the ones without metal sleeve led to better result. You don't need to be concerned about metal sleeves or lack thereof. This is a study done by my school, and I did a comparison. There was no meaningful difference, and the weight of the device before and after surgery was not really meaningfully different. If you do accurate surgery, you do not need to worry about the resin being grinded off. Important thing about sleeve design is the length and how close the sleeve gets to the bone. As you can see, sleeve how close it is to the bone. You can divide that into 3 categories. The sleeve needs to be very close to the bone to get better accuracy. On the far left is the use of drill key. So it extends the length of how drill is guided, and if the ones with a longer drill key have higher accuracy. Drill key is not really used in some systems, and in that sense, the sleeve length, the amount of guide that is being done also plays into the role. So guide needs to be properly done. And there's also discussion about open sleeve in the posterior area. There may be little limitation in how much the patient be able to open and close mouth. So you need to design the sleeve so that it is close to the bone. And open sleeve design can also be highly accurate. However, the farther away the sleeve is from the bone, open sleeve error increases. And depending on the system that you use, you need to make the right choices. This is a very important area, but internal fit. When you open window and then check the fit, you can see that it is adapted well with the teeth. When you try in, if it is not well adapted, you can grind off the internal surface at times. The factors that can lead to the internal error, if we consider that ahead, we'll get better results. So when you take oral scans and take impression using silicone, the grooves, it is very accurately recreated. But when we use 3D guide designs, the groove, if there is a little bit of error, the overall error of the template increases drastically. Therefore, sealing the groove is very important, and experimentally it has been proven that sealing the groove is very helpful. And on the software, you can provide offset. This will help in increasing the internal fit. Another issue that we need to focus is that how long are we going to extend it? The longer, the more it is extended, you can get a better stability. It needs to be adapted for all teeth, so the longer the guide, it is harder to get the right adaptation. So when you do experiment, if you narrow the scope, you can see that it's adapted to the designed way. As shown, and this is the study done by my lab. In different groups, these results are repeated. If you make the scope shorter, you can adapt it better. This is a 3D scan of it. If you move on to surgical stage, so in the accuracy of adaptation, in surgery, it's a bit of a different story. I've talked about it earlier, but when you do surgery, drilling is involved and it needs to be stabilized, and it's very important. As you can see, if the guide only covers 2 or 3 teeth, the instability increases and the level of error increases. Therefore, it should cover at least 4 teeth for the stability of the guide. So in summary, if you make full arch guide, there does exist possibility of inaccuracy, but if it is too short, instability increases. So when you make a design, you need to have a set of criteria to fabricate the designs. Vertically, how much of it should be covered? It should cover the over contour. If you make it shorter than over contour, it can be quite unstable as well. So upon design, when we define the border, the contour should be covered. Another concern is a deformation of the guide. This is done by my lab. And when you make a guide, and after 1 month, you can see that there is difference in root mean square values. If there's gap and if there's need to delay surgery, after you process it like this, even with time, volume change does not occur. Therefore, post-curing is very important. In surgery phase, I'm going to talk about it. As Professor Park has mentioned, he has mentioned about the deviation. And if you look at the different studies, if you look at systematic reviews in most studies, the deviation increase is above 1 millimeter. And the angular deviation is 3.5 degrees. At dental clinic, which we address smaller than 1 millimeter, this is quite a significant error. This is a scan body, and in order to assess the accuracy, this is something that we have devised. We attach it to the sleeve. The inaccuracy of surgical guide is less than what is thought of. 3D printed out before surgery, you can see that the guides are mostly quite accurate. This is a similar result, and this is a study result done by another group in 2022. This is the plan versus accuracy of the guide. You cannot really see the graph right now. If you look at the plan and guide, there's very little difference. However, if you move on to the surgery stage, the amount of error increases drastically. As you can see in the graph, planned versus guide, there's a very little error. But when placement is involved, the error increases dramatically. During surgery, you can see that there's a lot of deviation. What kind of issues lead to these deviations? First, the bone density. This is a 3D printed model. Different bone density is recreated. The higher the bone density, the more difficult it is to place as planned. This is using the surgical guide. If the density is high, drill shifting occurs more frequently, and inclination of bone. At times, there are slopes in the desired implanted placement site, and when we apply drilling, we cannot do the drilling as planned, but at times there can be drill shifting. We need to remember that. This is very true in immediate placement. Placement in extraction sockets. In this study, it compares a fully healed ridge and immediate placement. And when you use surgical guide, they looked at whether accuracy was seen. The study says that it is much safer and accurate to place a healed ridge because extraction socket there is a lot of slopes and drill shifting occurs very frequently. In the case of guide, compared with free hand, guide is more accurate rather than partial guide. Full guide is more preferred. That is the way to place the implant accurately. In this image, you'll be able to get a better image. In the case of immediate placement, the drill shifting occurs following the slope within the inner side. There's tolerance for that, and there can be drill shifting as you drill in the extraction socket. When you do immediate implant placement and in slope the ridge, you need to use bone flattening drill. That is recommended, or you need to start with shorter drill. And you need to make it so that the contact with the drill and the guide sleeve is maximized. Second issue is whether to use a partial guide or full guide. As mentioned, partial guide the accuracy falls down. It's the same in this study. Freehand has less of a accuracy. It's the same with another different study. Up to the implant placement, you need to use the guide so that you can get the accurate result that was planned. In this study, the premise was that in healed ridge, when you do it, there's not that much of a difference. The partial guide also shows very good accuracy. If it is sloped or if it is extraction socket, using full guide is more recommended. Third issue is the type of support and the effects. I'm sure you could have guessed, but tissue supported is tooth supported is more accurate. Second is bone supported. You put the guide on top of a hard bone, so it's quite accurate, but you need to make a guide based just on CT, and there can be issues associated with the air within CT, and you need to open flap very invasively. The most inaccurate is mucosa supported. Tooth supported, there are different factors that play in. If you take a look over here, if there is a tooth in the distal side, on the bounded side, there is more accurate, and if it is not bounded, unbounded tooth mucosa supported, it's quite accurate, but if it is unbounded tooth supported, drill deviation can occur significantly. These can be reported, and if there's a lot of distal extension, bone fixation screws need to be utilized so that you can minimize the shifting so that it can be accurately applied. So there are many studies on this. Bone fixation screws can be of great help. Tooth-supported device is fabricated to get more accurate result. When you do full mouth cases, if you leave some retained root, you make this device to place a couple of implants, and you use this placed implant to use it as a support after extracting the residual teeth. You can place 2 mini implants as shown to get a better result when you place implants. This is distal extension case on one unilateral arch. Many implants were placed on CT. You can use that as a landmark, and while it is placed, you can, because it is placed, you can use it as a support. So it's quite helpful. And this is a result report by Gyeongbuk University. And compared with the inaccuracy that I've shown you, it's much lower. So you can see that these really help. So I'm going to summarize what I've talked about. First, acquisition of data is very important. Silicone impression or intraoral scans should be utilized. Artificial markers should be actively used. If patient has whole teeth, if you have artificial marker, there are a lot of studies that say that artificial markers help. If there's metal artifacts, this is definitely a must-have. If denture, in the case of denture, you need to check the internal fit. Dentition, you need to do it precisely. And the metal sleeve or lack thereof is not really important. The internal fit of surgical guide is very important. The groove sealing or offset needs to be provided. As for the design, 4 teeth can increase stability during surgery, but it should not span too long. Finally, in surgery stage, the amount of air goes up. And if the bone is hard and if it is sloped, the error can increase. So we need to make a lot of measures so that inaccuracy does not result too much. Tooth-supported device is necessary. This is the end of my lecture. I hope this was of help. Thank you for your attention. If you have any questions, please email me.
들어주셔서 감사합니다.
Thank you for your attention.